VA Power Ribs 8 and 9. The family of the CA Power Rib now is increased by two new members, number 8 and number 9. The Power Ribs are MFM, Multifunctional Force Movement, MDI, Mesial Distal Inclination, DMI, Distal Mesial Inclination, FALA, Force Application Labial, FALI, Force Application Lingual, BUB, Build-up Bicuspid, BOOM, Build-up Molar, and the new members, BUAS, Build-up Anterior Small, and BUAL, Build-up Anterior Large. Here is a scheme how to use the CA Power Ribs, and the number 1 is used for force extrusion and force rotation, as you just know. Number 2 and 3 is to correct mesiodistal inclination of the crowns and roots. Number 4 and 5 are for the correction of the torque, increasing or reducing the torque. Number 6 and 7 are to build posterior build-ups on bicuspid and molars, and the new one are for anterior build-up on the palatal surface of the incisors. Here we can see models of the CA Power Ribs in a very big size, and this is the number 1, number 2, number 3, number 4, 5, 6, 7, and the new ones 8 and 9. Of course, we use the two-handle instrument for the power ribs, and here is the box with the power ribs, and now they come together with the number 8, BUAS, Build-up Anterior Small, and the BUAL, Build-up Anterior Large. The small is for upper lateral incisors, and the large is for upper central incisors. The idea to use anterior build-ups for the correction of the deep bite is not new, and we use normally the anterior deep bite treatment with build-ups. But now we are using the power ribs. Before having the power ribs, we correct with a clear aligner the intrusion in the model setup, intruding 0.5 millimeters at the beginning, and then continues with 0.5 or increasing to 1 millimeter according to the different patients' resistance to the activation of the aligners. But the very important thing is to control the torque during the intrusion, and for that we use the CA checker. Why it is very important to control the torque during the intrusion? Because we have to maintain the root inside the spongy bone, and if not, if we are increasing the torque, we are probably driving the apexes of the incisors to the palatal surface of the bone, or if we are reducing the torque to the labial surfaces or labial cortex of the bone. And if we push the teeth to the cortical bone, we are increasing the possibilities and the risk of root resorption, or as minimum we are reducing the capacity of movement of the teeth and the correction of the deep bite. So this is really important. When we use labial brackets or any kind of aligners, as the force is applied in a labial position if we take into account the center of resistance of the teeth, then we are intruding the teeth, but also we are increasing the torque. To reduce these possibilities, we add to the palatal surface the composite buildups, and then the force is applied more near to the direction of the center of resistance, and we are controlling much better the torque. We learned that from the lingual brackets, where the control of the torque is much better in deep bite cases comparing to labial brackets. Also, the clear aligner is designed to protect the gingival tissues during the intrusion, and then we are using a blue blocker to protect the gingival tissues, and in this case, the aligner is not damaging the soft tissues. As we talk, the first appliance is carried out at 0.5 mm intrusion, and at each following stage, 1 mm is intruded, but some patient needs only 0.5. In this way, it is easy to calculate how many appliances are needed to correct anterior deep bite. Normally, we don't intrude more than 2.5 mm the incisors, so maximum we use 3 or 4 aligners to correct 2 mm of deep bite. It's better to align and correct the torque before starting the intrusion. In intrusion treatments, the clear aligner effectiveness is always increased by chewing forces. In intrusion treatment, chewing forces significantly increase the effectiveness of the appliances, and therefore it is recommended to advise a patient to carry out soft chewing exercises with the appliance in his mouth. Here is a scheme of the treatment. First, we have a patient with a deep bite and extruded anterior teeth. Then we take an impression, figure scheme 2, and we have a model and intrude the teeth. The red line is showing the setup, intruding the teeth, 0.5 mm, and then in the scheme 3, we adapt the aligner. But when we come back to the mouth, of course, the aligner will have a stop in the incisors and it will not fit to the soft tissues, as we can see, and also the aligner will not adapt to the molars. But with chewing exercises, after 2 days or 3 days, the aligner inserts completely, provoking the intrusion of the anterior teeth. So we can see if the appliance have made its work because the aligner fits completely in the mouth. So this is the situation in the moment we insert the appliance in the mouth, and we can see that the aligner is not adapted to the soft tissues in the anterior area and to the molars. But after some days, we can see that the appliance fits completely because it has intruded the anterior teeth. Of course, we prepare the palatal surface and the labial surface with blue blocker in order not to damage the soft tissues after the insertion. Here again, before doing the intrusion of the anterior teeth and after doing this insertion. Sometimes could be necessary to increase the appliance retention in the molars area using the CA plier tip 1. On the other hand, clear aligner is not very effective in extrusion treatment, such as anterior open bite correction or intercuspation correction. In case that only one tooth extrusion is indicated, it can be achieved by additional composite retention carried out in the mouth in question before taking the impression. And for that, we use, as you just know, the CA Power Grip number 1 MFM. So before having the Power Grips 8 and 9, in deep bite cases, we prepare composite buildups, and this is a case with molar class 1, crowding, and anterior deep bite, occlusal views, and the orthopantomography. And to prepare the anterior composite buildups, we use the leaf gauge to determine the intrusion and the buildup's height. So we isolate the field and increase the folds of the leaf gauge until we arrive to the overbite that we want at the end of the treatment. So we are increasing the number of foils in the leaf gauge until we arrive to this situation. And of course, we will create a space in between the upper and the lower incisors. We isolate the field with cotton rolls, buccal separators, and aspiration, and then we acid etch the lingual surfaces of the incisors during 20 seconds, and then we rinse 10 seconds each tooth and dry. After it, we apply the primer, and normally we use composites that normally are used for fillings of any teeth. And then apply the composite, creating an artificial cingulum, asking the patient to close the mouth with the leaf gauge in position to fix the height of the composite buildups, and then we let cure the composite. And here we can see the composite buildups, and the same here. Then we can polish that, and this is finished. The buildups facilitate more effective intrusion because the CA clear aligner is better support to carry out, and furthermore the force is carried out towards the resistance center, allowing the better control of the torque due to the intrusion. So in this way we are controlling much better the torque during the intrusion. As we should know, we will create a space for the intrusion with blue blocker, and this is the appliance in position the first day. 2 millimeters intrusion in 3 steps for this patient, and here we can see before and after the intrusion, correcting the anterior deep bite. In the lab procedure, we use the CA Smart in the high position of the camera. We draw the lines as always, and of course we put the model in a vertical position, digitalizing the model, and after that we intrude 0.5 millimeter the first time and 1 millimeter the following steps. Create the space with blue blocker, and we can only intrude 0.5 to 1 millimeter, no more, because light forces don't interrupt the blood supply in the apical vessels, and this is really, really important. But it's much more easier to create the anterior composite buildups with the CA Power Grips number 8 buildup anterior small boas for upper lateral incisors, and the CA Power Grip 9 Bual buildup anterior large. And in this way we control much better the torque and increase the effectiveness of the intrusion of the anterior teeth. Normally the patients feel better, more relaxed muscles, because these composite buildups act as a relaxing splint, allowing the intrusion of the anterior teeth and also the extrusion of the posterior teeth. We use both handled instruments according to the better access to the palatal surface of the upper incisors. So we can use the angulate or the another instrument, and we use the buas with this shape for upper central incisors and the buas for the upper lateral incisors with this shape. We insert the power grip in the handle instrument, and then the only thing is to fill the CA power grip with composite and apply to the patient. And we can get shapes like this. And as we just talked, the anterior buildup acts over the mesencephalic to reduce the force of the closing muscles of the mandible, allowing the intrusion of the anterior teeth and also allowing the extrusion of the posterior teeth to correct an anterior deep bite. When we apply the composite using the CA power grip, we have to fix the final overbite that we want, so the inferior edge of the CA power grip should be 2 mm far from the incisal edge of the anterior teeth. And then we take the impression, prepare the setup model, and adapt the CA clear aligner. And this is everything that we need for that. So here is applying the power grips number 8 and 9, and we can use it with clear aligner or also with fixed appliances, as we will see. So here is the number 8 for upper lateral incisors, and then we fill that with composite, and after it we prepare the teeth, isolating the field with cotton rolls and buccal separator. Clean the palatal surface of the upper teeth with a prophylactic paste. Acid etch for 20 to 30 seconds, and then remove the orthophosphoric acid with the aspirator. Rinse and dry, and then the acid etching is finished. We apply the primer, and according to the manufacturer intrusion, we let cure the primer, and then we apply the composite with the CA power grip, and as we talked before, the incisal edge of the tooth should be 2 mm far from the lower edge of the CA power grip, and then remove the excess of composite and light cure the composite, and then after removing the CA power grip, we have the composite buildup ready to be used. We continue with the other teeth, and here are all the power grips used to make the anterior buildup. Sometimes we need to polish some angles or something like that of the composite buildups. Here are the patient ready, and we have to check the occlusion to get contact of the 4 anterior buildup to the lower teeth, and we apply the clear aligner. And here we have a deep bite case where we are using fixed appliances, but we cannot bond the brackets of the lower incisors because of the deep bite. And also we use the same procedure to use the CA Power Grips 8 and 9 to increase the vertical dimension and to prepare the composite buildups. So we clean the surface with any prophylactic paste. Then we acid etch 20 to 30 seconds the anterior teeth. Aspirate the acid and then rinse and dry, applying the primer, light curing the primer, and applying the CA Power Grip with composite, removing the excess, light cure, and here is the finished buildup for the upper left lateral incisors. We continue with the same procedure for the other incisors. And here is the case ready with composite buildups in the 4 incisors. And then we can see that this composite allows us to bond the lower brackets and also create a space for the molar extrusion in the posterior areas. So it is really easy to prepare the composite buildups using the CA Power Grips. Normally, we maintain the composite buildup creating an artificial cingulum and leave it for all the life of the patient, creating a cingulum that is really the retention appliance, not allowing the incisors to be extruded anymore. But if we have to remove that, we normally use the bars from Comet, the round one for the palatal surface, 314-023, or we use the 314-016. Thank you very much for your kind attention, and I hope that the CA Power Grip 8 and 9 also will be very useful in your practice.